My name's Nish and I'm an anaesthetist. We prepare a patient for an operation and we see the patient beforehand, go through how they are going to have the operation, provide an anaesthetic, which means that they're not aware during the operation and they're not in pain. There's different ways we can do that. We can put the patient to sleep or we can do numbing injections. There's quite a variety of things that we can do. At the end of the operation, we wake the patient up or we take them around to the recovery ward where they spend some time waking up and there's a recovery nurse with them until they're fully awake and comfortable and make sure they're not in any pain. You need to have very good team working skills because you're working with different people from different backgrounds that are all doing different jobs, and you need to get on with people. I think that's the main thing. I think of all the specialties in medicine, anaesthetics is possibly the most science-based. We're constantly monitoring the heart rate and blood pressure and breathing. So obviously that uses a lot of biology and chemistry. We use a lot of equipment which relies on quite an in-depth knowledge of a lot of physics. And also knowledge of chemistry and maths for working out doses. So it is very science-based. At school, I was always good at maths and science and I always enjoyed being with people and helping people. Then I went to medical school and anaesthetics had the biggest appeal to me just because I found it the most interesting. It's a lot about how the body works and how we can assist the organs in the body and things like that. Being an anaesthetist can be very challenging at times. We look after the patient all the way through the operation. You have to be on the ball and prepared for unexpected things to happen. So that makes it exciting, but it also can be very challenging. Anaesthetics is a great career. You learn so much, you work with great people, you're helping people through one of the most difficult things that they go through in their life. People, when they come to hospital and have an operation, they're surrendering a lot of control to you, and it's very stressful for people, and most of what we do is helping patients relax and helping them through that whole period, which is very, very rewarding.
Anesthesia is a method of pain management used during surgery or other operations by way of medicine called anesthetics. It aids with breathing, blood pressure, blood flow, and heart rate and rhythm. Its most common uses are relaxation, blocking of pain, fatigue or forgetfulness, or to induce unconsciousness. The use of this medical technique also aids in the reduction of anxiety, muscle relaxation, and physiological homeostasis in regards to hemodynamic stability, oxygenation, ventilation, and temperature. There are various types of anesthesia used specifically for different types of procedures. Local anesthesia is used to numb a small area without inducing fatigue or unconsciousness. Regional anesthesia blocks pain in a large area of the body and causes relaxation, but the patient remains conscious. Within this type of medicine, there are peripheral nerve blocks and epidural and spinal anesthesia. The former are used to block areas such as the hands, arms, feet, legs, or face, while the latter affects the spinal cord and nerves, blocking pain in an entire region such as the belly, hips, or legs. Finally, general anesthesia is used intravenously to block pain signals from being sent to the brain as well as inducing unconsciousness.
Anesthesia in its more general form has an extensive history dating back as far as 4000 BCE. Although there are certainly many unknown methods of pain management, some worth mentioning are 4000 BCE, opium poppy, 1600 BCE, acupuncture, 650 BCE to 393 AD, inhalation of ethylene fumes, 600 BCE, cannabis vapors, 400 BCE, carotid compression, 64 to 160, wine and herbal mixtures, 1350, chewed coca leaves mixed with vegetable ash and dripped in saliva applied directly to wounds. 1540, distillation of ethanol and sulfuric acid into diethyl ether. 1659, intravenous insertion of opium. 1771 to 1786, isolation of oxygen and nitrous oxide. 1779, magnets and hypnosis. 1805, morphium. 1847, chloroform administered to women during childbirth. 1884, cocaine. 1901, inadvertent epidural injection. 1905, Novocaine. 1944, lidocaine introduced as local anesthetic. From about 1964 on, scientists, doctors, and anesthesiologists alike have been working to perfect regional, intravenous, and inhalation techniques and ingredients for anesthesia. Arguably one of the most important, albeit inadvertent, anesthetic discoveries was the epidural. It has become one of the most popular resources for hospital-based childbirth since its discovery in the 1900s. The first recorded intentional usage of the technique was in 1909 by a German obstetrician who reported that of the 141 cases he studied, there was approximately a 50% success rate in relieving pain. The first epidural catheter, used for additional medicine insertion following the removal of the needle, was first used in 1931. Although the concept was discovered in 1901 and had been tailored for labor by 1931, it did not become popular until the 1970s. This is because of synthesized oxytocin, nowadays known as pitocin. Although incredibly useful for pain relief during childbirth, epidurals were causing contractions to slow or stop in about 40% of cases, a danger to both mother and child. However, synthesized oxytocin was used to augment labor and reduce the risks associated with delayed labor. Epidurals were not perfected until about 20 years ago. Prior to this time, they were more commonly referred to as caudal blocks, as they were inserted into the lowest section of the epidural system, or the caudal space. This manner of injection was harder to insert, required higher levels of medicine, and had the potential to puncture the baby's head. Such high levels of medicine were administered that often the laboring mother was unable to feel anything, thus losing the ability to push. Now, epidurals are inserted into the lumbar and have been fine-tuned to the point that mothers are able to elect which type of epidural they would prefer.
As far back as 1980, experts realized that the combination of marijuana and anesthesia may have adverse effects or even cause severe complications. This is becoming an issue among the younger population as marijuana is readily available in many states and users are scared of getting into trouble for using an illegal substance. Thus, they do not tell their doctor or anesthesiologist of their usage prior to the procedure. Marijuana is a depressant, which means it can lower heart rate and blood pressure, slow breathing, and decrease blood temperature. Anesthesia is also a depressant. The combination of the two may enhance depression of the central nervous system, therefore severely reducing breathing and or prolonging unconsciousness longer than the anesthesiologist had initially intended. In some cases, it may even cause laryngospasm, also known as the drowning reaction, which is a spasm of the vocal cords making it difficult to speak or breathe. The job of anesthetics is to make the body and surgery as comfortable and safe as possible. In this respect, anesthesia will be around for as long as people are having surgeries. In the same way, the basic goal of anesthesia will always be to control the motion of a patient undergoing a medical procedure. With new surgical techniques, anesthesia will have to progress to be effective in these new frontiers. It may even be possible for anesthesia in the end to be used as a medicine to help conditions like heart disease and mental disorders.
Anesthesia causes temporary amnesia by activating memory loss receptors done with the intention of stopping the brain from recording memories of the surgery. This is sometimes referred to as a reversible coma effect. Also, smokers require up to 1/3 more anesthesia than non-smokers, while those affected by secondhand smoke may need up to 1/5 more than those who do not. This is because smoke inhalation causes irritation in the airways, thus more medicine is needed to improve the breathing tube tolerance. There is an ongoing medical debate as to whether or not natural redheads may require up to 1/5 more anesthesia than others. The MC1R gene, or melanocortin 1 receptor, is responsible for both body pigmentation and pain receptor stimulation hormones. It is speculated that because of this link, redheads may be more sensitive to pain, resulting in the need for more anesthesia.